Okay, I'm going to talk about osteolysis, its diagnosis and treatment in total knee arthroplasty. Once again, my financial disclosures. I'm going to refer you to a paper that we wrote in the Journal of Arthroplasty that goes over this topic in much greater detail. What we do know is that when we've used fixed bearing prostheses with a single unit all polyethylene, there were no cases of osteolysis at 20 years. And here's an example of the total condylar. Once again, a all polyethylene fixed bearing monoblock knee. We went away from this in the early 80s with the advent of metal backing. Metal backing did things for fixation. It improved fixation on the proximal tibia by distributing the load better. However, it was quickly associated with modularity. And modularity, the ability to put a polyethylene insert inside the metal, is what created the problem of backside wear. On the top surface of a total knee, it sees pitting and delamination. However, in the backside, it sees more abrasion and adhesion, and that leads to smaller polyparticles, which are more biologically active. And here you can see the abrasion on the back of the modular knee, and that leads, or can lead, to osteolysis. The incidence of osteolysis has been somewhat higher in cementless total knees, around 6 to 30%, slightly lower in cemented total knees, maybe a function of the effective joint space, maybe a function of a variety of other factors, including the fixation. But we've done our own study where we were able to show that osteolysis with an all-poly knee at 243 knees at 5 years is almost non-existent, whereas with a metal back modular knee, it starts to show itself even as early as 5 years. And here's an example, all polyethylene on one side, modular on the other. 5 years later, it was put in 5 years afterwards. At the same follow-up, massive osteolysis on the modular knee. When you open up the knee, you can see a tremendous amount of bone loss in the distal femur and proximal tibia, and this requires bone grafting and a variety of revision techniques. So how do we diagnose osteolysis? Pain, synovitis, ruling out infection, and then getting the appropriate imaging. The first thing we need to recognize is that osteolysis in and of itself does not cause pain. We know this certainly from the hip, where we've seen many examples of asymptomatic osteolysis. But it is usually synovitis that causes the pain, synovitis associated with the fusion, or other times there are other problems, acute insufficiency fractures, component loosening, and occasionally a variety of other soft tissue problems. Early on in the disease process, it may be asymptomatic, but patients will start to complain of swelling, stiffness, and these are usually evidence of synovitis. And the place to look for synovitis is underneath the quad tendon. You'll see this thickening of the synovium. Occasionally you'll see it in the back of the knee as well and under the patellar tendon. So a knee that has very little osteolysis, you might make an argument that there's some there, has a massive case of intra-articular synovitis. The best thing that we can do is use serial radiographs to monitor these knees and look for advancing evidence of progressive osteolysis. And there are a variety of reasons for the rate of progression. It can depend on the patient's age, their host response, activity level, alignment, stability, the type of polyethylene, the locking mechanism, the fixation method, and ultimately the duration of implantation. The average time is about 31 months before the radiographic appearance of osteolysis, and in most cases, osteolysis will lead to femoral component loosening, but this takes quite some time. X-rays do not do a great job of diagnosing osteolysis in the beginning. So if you suspect it, there are a variety of things that you can do. You can try oblique X-rays. That can be helpful. but ultimately, as we talked about this morning, it's the emerging role of MRI and or CT scan. But in our institution, we have shown that MRI is more sensitive in detecting lesions, and it gives the added benefit of evaluating the soft tissues and looking at the intercapsular burden of wear particles. And here's another example where you can see a knee that looks relatively free of osteolysis, but on the MRI, early osteolysis is evident in both the AP and lateral. So this is our treatment algorithm. At 3 to 5 years follow-up, if you have a loose implant, obviously you have to revise it. But if it's well fixed, you have some mild swelling, you need to follow it up regularly. You can consider getting an MRI. Ultimately, if it becomes more and more symptomatic, you might want to consider a liner exchange. If it's symptomatic at that time and you've ruled out an infection, a liner exchange is certainly a possibility. Acute knee pain with swelling and established osteolysis would need either a liner exchange or possibly a complete revision. There's certainly, the use of bisphosphonates has been shown to be somewhat helpful in slowing the progression. It does not necessarily prevent osteolysis. Liner exchange does have some controversy associated with it. While Whiteside has reported good results, if the failure and osteolysis occurs early, there should be some concern about proceeding directly to a liner exchange. It may be indicative of a much deeper problem. So ways to reduce backside wear: improve polyethylene, improve the locking tolerances of the modular knees, use polished chromium cobalt base plates, consider rotating platforms, and or let's go back to one-piece tibial units, perhaps even the all polyethylene tibia. Thank you.